My name is Gillian Norton. I'm the chairman of the Trust. A very warm welcome to you all. I'm sorry I can't see you, and the technology has challenged us, I think, this evening. But I did want to open the meeting by thanking everybody for coming and by remarking, I think, about the very strong support we've enjoyed from our communities always, but particularly over the last few months. I hope you'll find the meeting interesting and informative and participative as we get towards the end of it. And we're going to start by asking people to agree the minutes of the last meeting, which was held just under a year ago on the 26th of September 2019. I hope those are agreed because I can't hear very much at the moment, so I'm assuming that that's all accepted.
Yes, we will go to the staff film and the staff story.
It's hard to remember the first few weeks of the pandemic now. It seems like a lifetime ago, but it was a really busy time for us. We were all working really hard across the Trust to try and get everything ready, and then we didn't quite know what to expect at the beginning. So as patients started to come, we were all learning as we went along, so we were having to change the way we were working depending on guidelines that were changing, depending on the PPE that we had, and we were learning every day about how to look after people with COVID.
We were the first area that had to receive all COVID positive patients in our area, and to receive those patients meant that the whole of my nursing team as well as the other MDT were not used to looking after respiratory patients and stuff. So the difficulty in managing the patients and looking after them was the initial phase. The second thing that we had is that we had to continue our service. Being the Tertiary Centre for Neurosciences, we had to still continue the services that we give.
The biggest challenge we faced by far actually was getting the wellbeing hubs up and ready. We literally begged, borrowed, bought furniture, rugs, lighting, and now we have probably some of the best wellbeing hubs in any hospital in London. And you know, well-being for staff is incredibly important. So again, we were incredibly proud to be part of this.
I think one of the most challenging things we all felt was the unknown. We were trying to prepare and plan for the intake of people, but the statistical analysis only goes so far. There were so many variables we couldn't account for. We were setting up boards, we were setting up equipment, coming in and working late over the bank holiday weekends just in case those devices were needed. It was better to have too many than not enough.
We were working really closely with the intensive care teams, with the haematologists, with the oncologists, with the palliative care team. It was a real sense of camaraderie, so we were all in this together. And I think, you know, that was a really positive thing that came out of it, and probably mentally helped all of us who were looking after patients with COVID survive it.
The team going well beyond, there are many examples, but I think the most that touched all of us is that most of the staff who would be in different shifts, like a day shift from night shift, or the nurses or the therapies who would finishing off at 3 o'clock, or the hostess, the other team that we have who are other allied health professionals, they would stay back after their regular hours and ensure that there is something to eat and drink for the other people who are coming in, or if there's anything else that they would want to do, like getting their phone charged, or getting any calls, or talking to someone else, or anything that they could do extra that would take the burden away from the other people, was something extraordinary that I thought.
The teamwork was incredible. There was no sort of overpowering hierarchical issues. There was people from all different disciplines, all different bands, all working together for the same goal.
The office of support and donations for community and individuals was incredible. We couldn't have done half the things we wanted to. In the end, we raised over £500,000, and we were able to use that money again as to support staff. We awarded COVID grants across hospital. We've also supported families who've lost loved ones who work at hospital. And again, everything that we did was reliant on that donation, you know, on the numerous donations. And for us, that's a critical part of who we are. You know, we help facilitate people. So thank you.
Oh, me, my team, I am the most proudest person, I would say. I think as a neurotriumvirate that we have, the clinical, we've had this discussion n number of times, that the best that I can think and take away from it, if I would say, is my teamwork. that we've been able to be a great team. They've given the utmost care, and to receive the compliments now when I see them, it's so rewarding.
I think the thing I'd be most proud of is being a small part of this incredible team that have looked after so many people with COVID. Of course, there have been some people that have had a really hard time, but the vast majority of patients have been able to go home, back to their families, back to their lives. And I think being part of an incredible team within the NHS has been a real privilege. I've learnt lots from working with everyone, and I hope we've all learnt to work together better as a result of this pandemic.
So we're going to move on to the staff story from Rafiq. Rafiq, are you able to?
Good evening, everyone. My name is Rafiq Badair. I'm one of the 3 divisional chairs at St. George's, but I think more importantly, I'm also one of the intensive care consultants. My colleagues who've just been shown in the video have sort of stolen my thunder in a way, because they've given a little bit of an idea of what it was like to experience COVID on the front lines during the period when we were all very pressured in the hospital. But I want to give you a little bit more insights into how things went from my perspective. Like everyone else, I'd started to hear about COVID at the tail end of 2019 as it started to spread in China. And at the time, it felt like something that was very distant, that would never affect us. It reminded me a little bit of when I was much younger following the SARS epidemic of 2003, which sort of seemed to eventually fizzle out. And I remember distinctly it arriving in Europe, in Italy, and starting to cause issues there. Speaking to one of our former colleagues who used to be at St. George's, who'd moved back to Italy, and I was discussing with him how they were coping, and it started to give us a little bit of a sense of what might be coming and the challenges that we would face. I started to feel a little bit uneasy about the future. And shortly after that, I remember getting a call from Jacqueline, who said, Rafiq, congratulations, you are the Southwest London lead for intensive care medicine. Well done. And can you please draw up some plans to quadruple our critical care capacity over the next couple of weeks? So very challenging times, not something I could say no to, given the circumstances and given Jacqueline asked so nicely. And it was a time where I had to work with my colleagues so that we could bring together some sort of plan to convert as much of the hospital into an intensive care as possible in as short a time as possible. And that was compounded by the difficulty that we really did not know what it is that that we were about to face. We didn't know ultimately how many patients we would get. We didn't know how sick they were going to be, and that was especially challenging. It was also challenging because we had to make that judgment call, because we knew that it would be very difficult for intensive care, and we knew that we would need lots of capacity. But the consequence of converting significant bits of the hospital to intensive care were that we were going to have to slow down or ultimately stop bits of the services that other teams were providing. And you always had that nagging doubt in the back of your mind, are we doing the right thing by stepping up all of this resource? And I remember the first patient arriving, and at the time, interestingly, our infectious diseases ward was actually undergoing a renovation. So the only side rooms where we could isolate these patients were actually on intensive care. And the first patient who was admitted to St. George's wasn't very sick. He was obviously unwell enough to warrant being in hospital, but not quite intensive care. I remember that middle-aged gentleman being in hospital in a side room on cardiac ICU. And then nothing happened for a few days. And then we got a second patient, and then nothing for a couple of days. And then it started to increase. It started, first there was this trickle, and then this avalanche. And in the space of a few days, we filled 2 of our 3 intensive care units. So it was very real and very pressured. And there were very surreal times where we were having to work very hard, both as a hospital organization, need to organize things, but also as clinical teams on the front line. And me and my colleagues, I remember distinctly, would be sort of in meetings, organizing things during the day, and then would go on to the intensive care units and look after the patients there. And I must say, it was the most surreal experience looking after these patients, partly because of how sick they were, partly because we were sometimes having to do it in environments that we wouldn't normally use as intensive care, so we converted many of our wards, and partly because all of those patients being this unwell, none of them had their loved ones around them, and so we and our teams had to fill in that sort of support for the patients, and also had to make quite significant efforts to keep in touch with the families, recognizing how distraught they must be to have loved ones who they may never see again in hospital and not being able to see them. Despite the difficulty, I think the things that struck me during that time were how hard everyone worked and how we all came together as teams. Despite it being very hard, even for us, sort of seasoned intensivists, if you like, people used to that environment, I can't begin to understand the courage of our colleagues who were seconded in from other specialties, who had never, some of them, never been on an intensive care unit, and who walked onto the unit in those circumstances and supported us in our time of needs as intensive care teams as well. I'm also very, very proud of the role that St George's played within the sector, supporting the rest of the southwest of London and other bits of London as well, because some hospitals were around, and so we were supporting both the southwest hospitals, but also northwest and southeast. So we played quite an important role, and I'm very, very proud of how hard everyone worked to deliver that. And I hope that we will be able to harness all that positivity for our future as St George's, and how we work both within the hospital and with our sector colleagues. And I'll stop there. I think that's enough of you listening to me talking about the difficulties of the experience that we went through. Thank you very much.
Thank you very much, everybody, for attending our annual general meeting this evening. I just want to take us through some points of last year in regards to the trust performance and what we've been doing in regards to our staff and our patients and in response to COVID. So have you got the first slide up, please? So thank you very much. I think it's probably helpful to remind ourselves about just a little bit about who St George's is, although I'm sure most of you will be familiar with that. It's sometimes easy to forget because sometimes St George's, it feels a bit like a family. It's a very friendly place. That we're actually quite a large organisation. We have 9,000 staff, and we serve a population both in South West London through Surrey and bits of Sussex of over 3.5 million people. We do on average about 50,000 planned operations and 650 outpatient appointments. So it's a large scale operation across the St George's main site as well as the Queen Mary site. So we're a big outfit. We're about 50% of the work that goes on in southwest London. Next slide, please. I think we've talked quite a lot about the coronavirus outbreak, and of course it goes without saying about how I am so incredibly proud of our staff who rose to a challenge which they'll probably only see or experience once in a lifetime. And the support that we have had from our local communities has been absolutely nothing short of amazing. We've had hundreds of thousands of pounds donated to our charities, to the coronavirus appeal, that we are using to support our staff. But just as important, we've had hundreds of letters from our local people willing us on and supporting us. Food parcels, paintings, children's drawings sent in, and as you walk around our organisation you will see them proudly displayed on doors and in corridors and on walls. Our ITU capacity is usually 66 beds, but we expanded that, as Rafiq has talked about, to 150 at the height of the outbreak in April. We had to reconsider, not only reorganise rotas and where people worked, but also reconfigure how we delivered services to keep patients safe during a pandemic that all of us were feeling our way through about what was the right thing to do. The majority of our outpatient appointments moved to online, and we expect most of those to stay as that, given we've had quite a lot of positive feedback from both staff and patients in regards to that. We treated over 1,000 patients with coronavirus during that time, and 1,000 patients recovered, but really sadly 300 patients died, including a very small number of hospital staff. And of course, whenever you lose a member of staff, that's incredibly difficult for all of us involved. Rafiq talked about the deployment of staff into ITU. And if you can imagine being an audiologist, somebody who does hearing tests, or that you usually work in our breast screening service, you can imagine how frightening and overwhelming that could have been. But I have to say, both our ITU staff and other support staff supported all of these staff, whether they be in ITU or on the wards, to meet the challenge of coronavirus head on and feel that they were supported through all of that. We also did an awful lot of work to try and keep relatives in touch with their loved ones. We had the charity who gave us a huge amount of laptops where loved ones could see and talk with each other, so they did manage to keep in contact in some way. Our South West London Pathology also had a massive part to play in setting up hubs, screening, in order to screen as many staff and patients as possible. And to date, we've done over 20,000 coronavirus tests for patients and staff, and this has been absolutely central to our response. So, like all hospitals, we are challenged to restart our normal services against a backdrop of different infection prevention and control measures, and also concern from the public about whether coming into hospital is safe. Of course, we continued all the way through this to provide emergency and urgent care. That's not only patients who came in to ED, but also patients who required life and limb level operations, as well as required urgent cancer procedures. Of course, like most trusts, we also saw a decline in patients both coming to the emergency care department and patients presenting with a heart attack or with stroke. We have 29 operating theatres at St George's, and during the pandemic we were operating out of 4. We now have 28 of those 29 up and running and seeing as many patients as we can who require a procedure. Our new infection prevention and control practices means that whilst procedures, some procedures are taking longer because of the amount of work we need to do within patients, between patients, and as we scrub. However, putting patient safety at the heart of what we do is absolutely critical, so we haven't and won't be complacent. Currently, the number of patients in our hospital with coronavirus has been 0 over the last few weeks. However, that has not stopped us putting in plans to manage any peaks or increases in the virus and patients requiring hospitalisation. We would encourage all of our patients to come to hospital because we're determined to keep you safe. So one of the things that we were incredibly proud of before we had to deal with coronavirus was that the Trust got out of quality special measures in March, which was announced the intention to do that in December. It might seem a long time ago, but at the time when we told our staff in December, they were absolutely thrilled that after 3 years, probably longer than that actually, being in special measures, to come out of that and to do that as Team St George's was really commendable. You can see for the results here that that we still have some work to do, but we saw real improvements across a lot of the board. There's been significant progress been made. and thankfully the Trust is now has less day-to-day scrutiny from our regulatory bodies. Of course, we have a real desire that we do give outstanding care all of the time, not some of the time, but all of the time. And we fully intend to continue that. I'd just like to give you some highlights. Next slide, please, from the CQC report. So the Trust was rated requires improvement overall. And the inspectors commended the staff and the leadership team for the significant improvements we have collectively made together. What made me feel particularly thrilled was that our services to children and young people was rating outstanding, and surgery, of which we do a huge amount in this organisation, was rated as good. And I know the surgical team are very determined to get that to outstanding. And outpatients, which had been doggedly in the wrong red category, was moved upwards to require improvement. It's right that we recognise cardiac surgery as we go through the review of last year. The cardiac surgery mortality review was published in March of this year, and that review undertook a review of 220 notes of patients that had died over a 5-year period, and was undertaken by 12 individuals, a mixture of cardiologists, cardiac surgeons, cardiac intensivists and cardiac anaesthetists, and they reviewed through a structured judgment process those patients against a list of criteria. Out of that, they found failings where definitely, most likely or probably, the care that we gave those patients resulted in the deaths of 67 of those patients. It's absolutely right that we apologise for the failings of care that they identified, and we continue to meet with families that have affected to go through the findings of that review and continue to give an unreserved apology to them. Both the Care Quality Commission and NICOR, who looks at the mortality rate in cardiac surgery units, have confirmed that the service is now safe. However, our cardiac surgery unit remains under close supervision and monitoring, both by ourselves and our regulatory body. So when we look at our performance over the last few years, in regard of ED, in 2000, we have seen a reduction in that over the last 3 years. However, what I am pleased to report to you is over the last few months, our emergency care department has been above 95% consistently during that time. In fact, it's performing so well that we are in the top 10 trusts in the country, and there are 132 trusts who report emergency care performance. We also had not been reporting our RTT, so that is how long patients requiring outpatients or a procedure have to wait. And we were beginning, before COVID hit, to get on top of both the performance as well as the long waiters. Unfortunately, as COVID has hit and we didn't do very much operating, we still have a mountain to climb in order to get back to where we were pre-COVID. We've always been very good with our diagnostic waits over the last couple of years. Last year we found we had a backlog in cardiology echo patients, which we were beginning to address, and we continue to address all of the diagnostics waits going forward, where again we couldn't see all of our routine patients that we needed to. MRSA, we need to do 0. Last year we did 3, the year before 1, and the year before that 5. So something we constantly look at in terms of hand washing, hand hygiene. So in regards to delivering improvements for patients, we've had some very positive developments. When I started here, one of the big issues for staff and patients alike was the quality of our estate. We've started to refurbish our wards, and this year we've done Heberden and McKenty wards, and they do look smashing. Our ward accreditation system, which has been nationally recognised, goes from strength to strength, and we see our staff really engaging with the accreditation process and wanting to push themselves harder in terms of getting to a gold accreditation. Our neonatal service is now UNICEF baby friendly. and recruiting to clinical trials is one of the highest hospitals in London. You might ask why that's important, but it's important that we test out research and develop research so that we can begin to give tomorrow's treatments today. We're very keen to be on the front foot in being innovative and research practitioners to deliver these treatments for patients. We've also developed our critical care outreach team, and that means we have experts linked to ITU who can go out to the wards to look at patients or support patients who look like they might be deteriorating, and either help support staff make them better, but also admit them into ITU should that be the case. One of the key diagnostics areas we look at is to make sure that patients don't go into a peri-arrest. So that's one of the key indicators that we are tracking. Also, that we have something called treatment escalation plans. So we determine with patients and their loved ones the ceiling of care they want to go. So do they want us to resuscitate, or do they want us to stop at a certain level? And that's a decision made together about where do we want to go with your care if you get really poorly. So we've been doing an awful lot of work to keep patients safe, to make sure we follow their wishes, and to capture patients before they get too ill for us to treat as well as we could do. I want to talk about the developments for care of our staff. Our staff, next slide please if you can. Our staff spend probably a third of their time at work, and we really need to make sure that when they come to work they are supported, they enjoy their work, and they feel that they want to come to work without fear or reprimand. Looking after our staff is one of the most important things that we do. Last year our flu vaccination rate was the best in London and the third best in the country. For me, that indicates we have staff that are engaged, and I'm just going to give a shout out for Patricia there on the left, who is a force to be reckoned with in terms of educating our staff about why flu vaccinations are important. We're also really grateful for the St George's charity because they have funded the wellbeing hubs that you saw on the video. And there are currently 2 at St George's Hospital, and they've been of a great place for staff to go rest, recuperate, and have a little bit of looking after on the site. Again, several years ago, one of the biggest issues that we had was that our IT was not fit for purpose. Half of our hospital had it fully on the wards, half didn't, and it was a huge concern for patient safety. We've not only been able to roll out our IT across the whole of St George's, but also now at Queen Mary's Hospital. So we all have the same IT system that ensures that patients are safe as we move them across sites. We've also improved and added to our network of Freedom to Speak Up Guardians. We want our staff to tell us if something is wrong. And if they don't feel safe to talk to their line manager, then the Freedom to Speak Up Guardians are there to help them when there are times of difficulty and they need a safe space to talk, and also to help sort out the issues that our staff are finding. So we're really pleased to see that they're out there helping staff raise concerns if they feel they need to. I talked at the beginning about how pleased I was and how I've always been celebrated the fact that 47% of our staff come from a BME background. And this year, diversity inclusion is something we've talked a lot about, both because of the disproportionate effect of COVID on the BME population, but also because of Black Lives Matters. And I think it's true to say that we've heard some stories from our staff that have been deeply uncomfortable and upsetting about how they are treated. So both myself and the chair decided to take more decisive and clearer action. We've appointed a Deputy Chief People Officer whose role is to work with staff, particularly around diversity and inclusion. And we've done a huge amount to work with our divisional teams and our corporate teams around how do we listen to staff, how do we support our BME staff in the interview process, how do we give them coaching and development. We've also developed a toolkit which has been gone down very well in the organisation about how to talk with BME staff. A lot of our staff, white staff, feel concerned that they might say the wrong thing or they might get it wrong. So how actually to actually have really healthy, good conversations collectively. We've also begun a big major piece of work on organisational culture, which we're in the diagnostic stage about what actually is our culture, what do people think about working in St George's, what are the good things about that, and what are the things that they want to collectively change with us about that. And hopefully this time next year I can talk more widely about what the diagnostic says and what we are doing together about improving the culture and the working of our staff, and really the work around diversity and inclusion, which isn't just about BME staff. There are 7 protected characteristics as well. Is all about how we behave together and how we behave towards each other, and making sure we are respectful, responsible and kind to each other. The last slide really is about how we look forward. Since Gillian and I started in 2017, we've worked very hard with our teams to make St George's a more outward-facing organisation with stronger links to other providers and partnerships organisation. In 2019, we published our 5-year strategy, and one of our 4 key priorities set out in the document was closer collaboration. With the COVID-19 pandemic, actually, we've become far closer as provider organisations across South West London, and we are working collectively together for the benefit of patients and staff. As we move forward, we will see even closer collaboration with some partner organisations, and we view that this will be a very positive step, both opportunities for patients and staff to have great care, both collectively. So with that, I'm going to stop, other than I understand that the chat function is problematic. So if people could submit questions to the website, to the email address, members, oh, it's gone now, members at, I think it says St George's, I just need to get that up and running, members at stgeorges.nhs.uk. That's members at stgeorges.nhs.uk. So please submit your questions via that route if you are able. Thank you so much for listening.
Thank you very much indeed, Jacqueline. That was a really comprehensive review. I'm sure very interesting to people. I'm going to hand over now to Andrew, who's going to talk about money. Andrew.
Thank you. Now for the part of the evening where you probably wish that the technology would fail, so you don't have to listen to me talking about the accounts. I'm here to present the financial statements for the financial year ending 31st of March 2020. These were audited by Grant Thornton, who've been our auditor for several years now, and the key audit conclusions were that we received an unqualified audit opinion, and except for conclusion in relation to securing economy, efficiency and effectiveness in the use of resources. This is an improvement on the adverse conclusion we had in previous years. The key reason for that is we haven't been able to remove the deficit from the organisation, we have been able to significantly reduce its size. And the only sort of key change within the scope of the audit was the issue of COVID-19. While that is predominantly an issue in the current financial year, it did impact on the end of last financial year, and also it was a very live issue during the course of the audit, and that's something the auditors need to take into account. Unfortunately, the Trust remains in financial special measures. That's largely a consequence, partly of the fact we are still in deficit, but also partly the focus, I think, on COVID and changes within the wider NHS has meant they haven't actually constructed the mechanisms to remove organisations from that. But certainly our financial performance is now currently much in line with the bulk of NHS organisations in England. Moving to the next slide, please. The key elements of financial performance were our deficit for 1920 reduced to just over 13 million, which is a reduction from 45 million in the previous year. Our income increased by 62 million to 906 million, and our expenditure going up by 30 million to 920. Key issues to note, I think, in there is we received what's called provider sustainability funding. This was made available to all NHS organisations in respect of being able to close and hit our underlying financial plan. We missed by a small amount. As you said, we were overspent by 13 million, predominantly as a relation to pressures within our medical workforce and also shortfalls against our CIP targets. I think it's important to note with the CIPs that while we were about 5 million short, we had a target of 50 million, of which we delivered 45. So it was a significant target, larger than most other organisations. So 45 million delivery against 50 target is a very good outcome. The plan for last year was challenging, so therefore to deliver a 13 million deficit overall was seen as a reasonable success. Obviously, we would have preferred to have hit the overall planning target. Capital investment was also up last year, totaling nearly 57 million, an increase from 24 million in the previous year. We were able to secure loans from the Department of Health to help with some of the key investment issues within our estate and IT, and Jacqueline's noted some of those earlier. And our borrowings were in line with the overall scale of the deficit and the capital investment that we see standing at 65 million. Move to the next slide, please. Just looking into the current year in the sense of as that goes forward, I think it's worth noting COVID-19 is the significant issue in relation to our financial performance in the current year. The NHS largely suspended the normal planning rounds, and we have been supported, as of all trusts in England, to a break-even position so far across the current year. We are working, the NHS is working to define exactly how that will play through the remainder of the year, and that's largely dependent on the planning being completed to deal with winter and the next COVID surge. We expect shortly to hear how that will be managed. But so far we are break even to the end of the 5th month of the current financial year. Our borrowing is not expected to request any working capital loans in the current year, but we will obviously take loans in relation to capital. And we expect quite, again, significant capital investment. We have a capital plan of at least 50 million in the current year, and we are trying to secure some additional capital funds as well, in potentially up to 35 to 40 million. Above that, so we could have nearly 100 million of investment. This is to address not only some of our backlog issues, but also addressing some of the investments that are required in relation to COVID. I think it's also just worth pointing out that our historic revenue and capital loans, totaling about 320 million rather, were converted into public dividend capital on the 1st of September. That's beneficial to us because we won't need to pay interest or repay the principal of those loans, but we will need to pay a 3.5% dividend as is standard on all PDC. That's great. Thank you very much. For those, hopefully there was no further comments then from our external auditor. On that basis, I will hand back to Gillian.
Thank you very much indeed, Andrew. And so I think it's incumbent on me to say some thank yous to the governors under Richard's leadership, who do fantastic work for the trust. They have two main roles. One is to be in touch with our communities, our patients, our members. We like as many people as possible to be members of the trust, and the governors are a conduit between the organisation and members, and they're extremely effective at representing the public and members' views to the trust. And the other key role they have is to hold the non-executives to account for the performance of the board. And they work incredibly hard at that, and I think they do a very effective job as well. Certainly we've just spent 3 hours earlier this afternoon in part briefing governors, and then as non-executives answering their questions on a whole range of issues so that they can satisfy themselves that we're doing our job properly. I'm conscious that I haven't done Richard's presentation justice, but I hope that I have given you a sense of what our governors do and how important they are in terms of the overall governance of the trust. And now I think we're going to try to move to questions, which we will try to answer to the best of our ability. There are a number of executives actually in the trust, and some of you may be wondering why they're not wearing masks. They're not wearing masks because they are socially distanced. We thought that it was better to have them there and distanced and not wearing a mask so that they could be heard more clearly. But I didn't want anybody watching to think that we weren't paying close attention to the importance of infection control. And I think somebody said earlier that the adherence to the mask policy and social distancing in the trust is something we take really seriously. And I hope actually that the picture does show that there is effective social distancing going on. Some of our executives will be dialing in, and as you will have been able to see so far, we've been beset by technical problems. So I think we're all just going to have to go with the flow. And if I pass the question to somebody who in fact hasn't been able to make the technological link, then I will have to pass it to somebody else, probably the chief executive. So she's on notice of that. So I believe what's now going to happen is that Chris Rolfe, who is the Trust's Director of Communications, will read out the question. He's compiling a list from the questions that I hope you're submitting, and then I will seek to allocate it to one of my colleagues. This is the bit I'm a bit nervous about, because I'm not sure it's going to work as seamlessly as I would like. And as I say, Jacqueline might end up answering quite a lot, but I'm sure she's ready, willing and able to do that if necessary. So I hope, Chris, if I now mute myself, you will be able to read the first question to us. Is that right?
Yes, thank you, Gillian. We've had a number of questions which I will read out now. The first question is, what are you doing to treat patients who suffer from mental health conditions with respect and dignity?
I would like to give that to Rob D, who is our acting chief nurse, if that's okay. Rob, are you happy to take that question?
I am, thank you, Gillian. Throughout the pandemic, we've continued to care for patients presenting to the emergency department who suffer with mental health conditions. We've been working closely with our mental health providers across South West London, specifically South West London St George's Mental Health Trust, to review the pathway for our patients. And they've implemented a number of new initiatives, such as an emergency assessment area at Springfield Hospital, that's allowed us to direct patients who are clinically stable and well enough directly to the mental health hospital, where they can provide treatment to them in a timely manner rather than waiting in the emergency department. Unfortunately, there are a number of patients that are required to wait in the emergency department who are medically unwell or need immediate treatment from our mental health team who are based here on site. Those patients are assessed and prioritised in line with recognised clinical triage protocols in the emergency department and cared for in dedicated areas within the emergency department with adaptations to make it a safe environment for them, such as anti-ligature areas.
Thank you very much indeed, Rob. Thank you for that. Chris, could we go to the next question?
Yes, thank you, Gillian. Is from Norman McLean. I wish to congratulate the Chief Executive for her anti-racist policies, but question if two racist practices at St George's continue, namely, one, are undocumented migrants still at risk of being denied treatment? And two, are the hundreds of outsourced workers, overwhelmingly people of colour, still working for paying conditions below NHS staff?
Jacqueline, are you happy to start that? I might have to hand it on to Andrew.
Yes, I can start that. So we follow the national guidance or law in regards to that. So anybody who turns up to our A&E or our maternity unit who requires urgent emergency treatment, we will treat regardless of where they've come from and who they are. So we will always do that. However, for more elective procedures, then we maintain the rules that are set out by NHS. By the NHS in regards to that, and we've always been very clear on those points. I don't know if Andrew wants to say any more on that, because it tends to fall a little bit in terms of the finance bit, but we still remain as we've always been very clear on those points.
Thank you, Jacqueline. Andrew, could you please deal with the outsourced staff question?
Yes, I can. With outsourced staff, they're on a range of terms and conditions. If staff are transferred from St George's, they will be entitled under TUPE regulations to remain on, which would largely be Agenda for Change. Staff who are newly then recruited to those services would usually go on to local wages. The majority of our providers comply with the London living wage in terms of the terms and conditions that they offer to new employees to their organisations. We continue to work closely with all of the suppliers around those conditions to ensure that those wages are fair and appropriate, and they comply with the requirements of the London living wage and the contract terms that we set with them.
Thank you very much indeed, Andrew. Chris, could we have the next question?
Yes, thank you, Gillian. What plans did the hospital put in place before the COVID-19 pandemic struck?
Now, I would like to pass that to Avi, who is our Chief Operating Officer, if she is available. Otherwise, I think I'll probably have to pass it to the Chief Executive. And I think Avi might be struggling with a connection. Does anybody know the answer to that?
Avi? I don't know if Avi's on or not.
Avi's struggling, Jacqueline. So do you mind answering that question about our preparations for COVID?
And this might be something joint with Andrew, because I was shielding at that time as well, and I'd only just come back from sick leave. So I think we might have a joint effort between myself and my deputy, as he was acting at the time. So, or it still is. I think Rafiq started to talk about beginning to see what was happening in Italy, and I think we had first very close knowledge of that because of the relationship we have with one of the professors in intensive care in northern Italy, who used to be our clinical director for ITU. So we were aware it was coming, and we started to put plans in place in regards to what we would do to try and increase ITU, what we would do to try and segregate COVID patients, where we would put COVID patients. We seconded actually one of our ex-medical directors, Ros, to actually come and work with how we changed our rotas and how we got staff into ITU. I think that took a little longer than we needed it to do, but we did do that, and we did that very well. And also how we communicated. I mean, to be fair, we did have to feel our way through some of this. There was no footprint for us to actually do this. We were learning from each other in South West London about what we needed to do, what people had found had worked, and I think the clinicians, and I say that in the widest clinicians, nurses, doctors, therapists, AHPs, they collectively grabbed hold of this and actually organised quite a lot of themselves. Actually, they did a superb job. But we, organisation and staff rotas, making sure we could stand up ITU, making sure we could organise on the wards, looking after COVID patients, standing down a lot of patients for elective care and outpatients. Huge amount of work went into that as well. Making sure we were communicating on a daily basis with staff about what was going on, because what was coming out of central government and out of the Department of Health was changing on a daily basis, making sure that we had enough PPE to actually keep our staff safe. And that was quite difficult, given there was quite a lot of upset with staff about the guidance from the World Health Authority on PPE. But all of those things and more, we were making sure on a daily basis, before, during and after COVID, that we had all of that there, as well as staff health and wellbeing, which is, as I said, we've got about 30 psychologists in the organisation. Most of those actually look after or do psychology with patients. Some of them is for staff, but they joined together actually because there wasn't many patients in regards to that, and actually did a sterling job going around the wards and departments supporting staff, and also a big job for us about getting staff who needed to shield or didn't need to be in the organisation back at home and supporting those staff so they felt that they could be part of the effort but didn't need to come in. So all of that started before COVID, but sort of really ramped up as we began to see the figures beginning to go up. And I think it's true to say it was very difficult to know how far to go because we were relying on the modelling nationally to actually point about what we needed to do. So a mixture of both. And I don't know, Andrew, whether you want to add any more to that because you were on the site actually in the middle of it.
Andrew, do you want to? I think that was quite comprehensive, Jacqueline, but there may be one or two things you wanted to add, Andrew?
Just a couple of comments, I think, in the sense of being there on the ground. What struck me, I think, was the I think Rafiq mentioned it earlier in the sense of how a trickle became suddenly an avalanche, I think his words were, in terms of patients. I think the organisation responded marvellously in the sense of everybody pulled together. I think the organisation did really well in terms of staying ahead of the curve to ensure that we were not standing down services too quickly, but making sure we always had enough capacity to deal with the patients coming through the door. So, and I think that balance was a very difficult one to strike, but I think we did very well. But the thing I remember is, you know, we would call meetings at short notice to try and organise events, and there would be a marvellous turnout. Everybody would be there, everybody would be willing to help, and everybody went the extra mile. So I think if I take away, you know, that one positive when I look back to those days, it's the fact the organisation really galvanised itself and pulled together massively to ensure that we could provide, you know, the best care we could in very difficult circumstances.
Thank you, Andrew. Can I endorse what both you and Jacqueline said? The team effort and people's preparedness constantly to go that extra mile was astounding to witness, and I felt so proud of everybody's contribution. Could we move on to the next question, please, Chris?
Will do, Gillian, thank you. This is from Councillor Graham Henderson. Page 76 of the annual report refers to the newly established Diversity and Inclusion Steering Group, which is welcome. Can I ask, how many in this group are BAME staff? Does its influence or work extend to contractors who work within the trust? And also, what involvement is there with the trade unions who represent staff?
Thank you very much for that question. I'm going to start with the answer, if that's okay, because I chair the group. But my colleague Humaira, I believe, is on the line. And Humaira is the Deputy Chief People Officer who works in this area and has responsibility for this area. So we had the first meeting in July, and I think everybody felt it was very important that we tried to have the meeting in person because we've all seen the limitations of technology, unfortunately graphically illustrated this evening. And it meant we had to find a very large room so that we could properly do social distancing, because the same problem I referred to earlier, if we'd been wearing masks, I think some of the essential communication and getting to know each other, which was such an important part of that first meeting, would have been lost. So all the various protected characteristics are represented at the on the meeting, on the group. Not everybody was able to be there because I think we had a couple of people who were shielding. But my recollection, and Humaira will correct me if I've got these numbers wrong, is that there were 4 BAME members of staff, and our staff side secretary represented the staff side, which of course includes our unions. Humaira, are you there, and did I get that right?
Yes, I think most of that's correct, yes. I think we had a few of the BME staff, and we had 4 networks. I think that's what the numbers were, 4 different networks, the leaders of 4 networks. And it was certainly quite an interesting discussion, and it was focused very much on BME issues. I remember that very well.
Yes, it was also quite an emotional meeting, I think, because everybody was given an opportunity to speak, and the leader of the BAME group asked if she could go last, and it was quite deliberate because she didn't want. She wanted to make the point that all protected characteristics are important, but inevitably we did spend a lot of the meeting listening to her and her colleagues, other black staff, talking about their experiences, and it was hard. Some of it was hard to listen to. It is very much at the moment a group that represents employed staff by the trust, and I think the point that was made in the question is an important one that we will have to give attention to, I think, because we do have contracted staff in the trust. They are an important part of the team because it's only working together that we provide the best care to patients. And so I think that is a good reminder for us to pay attention to that question and see how we can pick that up adequately. Thank you very much indeed for the question. Hamira, sorry, did you want to add something else?
Yeah, I just wanted to add something because I just today actually met with the BME network lead, and the same lady that spoke very strongly about the issues, and she said at that meeting in July that there were 250 issues that came to her about issues that people were feeling. That's significantly down. In fact, a couple of weeks ago, she hadn't heard anything, any issues raised. Some few of them are creeping up, but I think we are making a lot of progress in terms of some of the issues that were raised, and they are being acted on at the moment. So I think that's a good indicator that we are responding to the issues.
Thank you, Hamira. And I think it is worth emphasising again the point the Chief Executive made about the fact that she and I have been quite outspoken to the organisation about our determination to make a difference, and we've had some really touching and positive feedback from individual members of staff who've spoken or written to either Jacqueline or myself or both of us. So this is very much a work in progress, but as Hamira, I think, said, I think we in the last couple of months we've probably made a lot more progress than we did in the months before that. So thank you very much indeed for that question. Chris, could we move to the next question, please?
Yes, thank you, Gillian. And I'm just going to briefly say that we have had a lot of questions, and particularly those submitted in advance, we will respond to in writing if we can't address them this evening. So in terms of the next question is, should I get a flu jab? Won't I get mild symptoms that could make me more susceptible to COVID?
So I've got to resist the chairman's temptation to express a personal view on that. Is that one for you, Rob?
Gillian. Thank you, Gillian. I do have a personal view on that, and also a public health message view on that. I would encourage anyone who's eligible for the flu jab to absolutely get the flu jab. It's a key component of our public health campaign for England and the UK. We know that flu can kill people as much as COVID can. We move into winter not knowing the impact of flu as well as COVID. And winter always puts additional pressure with flu on health services, and now we have the added component of COVID. We would encourage our staff, our patients and members of the public, if you're in an at-risk group over the age of 65, and this year the government is also reducing the age to above 55 to see your GP or your employer or pharmacy to get a flu jab. In terms of the worries about does it give me flu, and that's something that our staff as well as relatives often ask me and say, oh, the flu jab gives me flu, I feel unwell. It's an inert vaccine. There are different types of vaccines, so it's dead. So you don't get the flu, but it does generate an immune response, so you develop antibodies. So with that, you may get a mild headache for a day, you may get a low-grade fever. What we say is drink lots of fluids after having the flu jab. You might get a bit of redness around the injection sites. Take some paracetamol, drink some fluids, and that should pass very, very quickly. If you become unwell longer than 24 hours, then that's unlikely to be due to the flu jab, and you should seek guidance from 111 or your GP. So I would absolutely encourage anyone that's applicable for the flu jab to have the flu jab this year.
Thank you, Rob. I would have said the same, but not nearly as eloquently as you. But the Chief Executive also wants to add to this. Jacqueline.
So I just want to give something personal about the flu jab. I've had the flu jab every year and I've never had an effect from it. I had the flu jab this year, and I've been quite open about the fact that in December I was admitted to hospital for 3 weeks with influenza A. But I know that if I hadn't have had my flu jab, I probably wouldn't be here today. So even though I was incredibly poorly, having the flu jab actually mitigated some of the symptoms that I had in regards to that. So have your flu jab.
I think there's a very clear message there coming across from all of us. Can I just say that Chris has referred to a lot of questions. I'm perfectly willing, as I know my colleagues will be, for us to extend the finishing time in order that we can take as many questions as possible. I mean, there comes a point where we can't keep going, but I think we'll certainly keep going till 7:45, and I hope that means we can get through more questions. Chris, the next one, please.
Thank you, Gillian. What steps is the Trust taking to reduce carbon emissions and support environmental initiatives in Wandsworth in relation to building projects, staff travel, incineration and waste disposal, and how are they measuring success?
Thank you very much, Chris, for that. And I'm hoping that that Andrew, our Estates Director, is here. He was certainly here earlier. And I wonder if our our Chief Finance Officer, also an Andrew, minds if I pass it straight to Estates Andrew. Is that okay? Are you still there, Andrew?
I am. Thank you. I'm happy.
Is that okay for you?
Yes, of course. Thank you. We are just working through producing a brand new estate strategy for all of our estates, and a key component of that will be how we deliver our proposed new developments sustainably. And we are working, I've been in post for 3 months. We have built some great relationships with Wandsworth Borough Council on exactly these issues. So we're working with them on the moment on sustainability, and particularly on travel planning as well. So it's something that we will be considering as part of our new estate strategy.
Thank you, Andrew. Lots of promise for the future, but some good starts made, I think, is the summary there.
Yeah.
So thank you. Chris, could we move on to the next question?
Yep. Next question is, what is the current state of the hospital in relation to COVID-19? And what is the current state of the hospital, re normal admittances, treatment for cancers, etc.?
Thank you very much. I'm told that Avi Bhatia, our Chief Operations Officer, is now online and able to answer this question. I hope that is the case. Is it, Avi?
Yes, it is. Thank you, Gillian. Good evening, everyone. So in terms of the hospital's current status, at the moment, as Jacqueline said in her presentation, we haven't actually had COVID positive patients arriving in our emergency department or being admitted to hospital. We have had patients who have got suspicion of COVID, and we manage them accordingly. We swab them and test them and make sure that we've got a diagnosis, but we haven't seen high activity of patients coming into the hospital with suspected COVID or confirmed COVID. In terms of the second part of the question, in terms of cancer, I think the key thing to say there is, even during the peak of COVID, as Jacqueline said, we kept theatres running, nowhere near at the level that we are aiming to get back to now, but we did keep theatres running. And some of the activity that we did do through those theatres was urgent cancer surgery. We also have been working with the Cancer Hub with the Royal Marsden in terms of getting urgent cancer treatments carried out. We're now obviously increasing our operating, and we are working very, very hard to offer the same level of activity as we were doing pre-COVID levels. That is challenging because we have to have new patient pathways in line with infection control and additional precautions that we need to take in how we manage the pathways. But that is what we're aiming to do now, whilst we continue to work with the Cancer Hub at the Marsden and as appropriate in the independent sector as well. So getting patients treated for cancer, whether it's diagnostics or actually surgery or indeed chemotherapy later on in their pathway, that is an absolute prioritisation for us.
Thank you, Avi, and lovely that you're able to join us. Delighted to see you. Chris, the next question.
Thank you, Gillian. How much money in extra terms has COVID cost St George's, and is this money likely to be reimbursed by the government?
Definitely one for Andrew Grimshaw.
Across the first 5 months of the current year, we've spent £15.3 million. And as I said earlier, we have been supported to a break-even position. So yes, that funding has been supported. We anticipate currently to, we're working through the costs of what we're likely to incur between now and the 31st of March, i.e. through to the end of the financial year. While we can scope some of that in terms of the plans we're taking, there are other aspects in terms of the scale of the surge we'll see and the impact that have that we can't see yet until it happens. But our best estimates as they stand at the moment is we'll spend a total of £46 million in the current year on COVID. And again, as I said earlier, what we're waiting for is confirmation in terms of the funding arrangements for the second half of the year. Again, we expect to receive those shortly. But as I said, for the first 5 months of the year, we have broken even, having spent 15.3 million on COVID.
Thank you very much indeed, Andrew. Next one, Chris.
Thank you, Gillian. Another question in relation to COVID-19. Are staff now catching up on leave, shorter working hours?
Is Elizabeth with us? Elizabeth is our other Deputy Chief People Officer. I think, Elizabeth, would you be happy to take this?
Yes, Gillian, thank you. It is correct. We've asked all line managers to encourage our staff to take annual leave. As over the last two months, that has been the message we've been putting throughout there. We recognize that we need our staff to rest and be well before we get into the really busy winter period. So yes, we are encouraging staff to take annual leave.
Thank you, Elizabeth. Chris?
Thank you, Gillian. Another question about COVID-19. What has been learnt about the disease in room?
Do we have Richard Jennings with us? Indeed we do. Richard, I think this is probably one for you.
I think we've learnt a huge amount about COVID-19. And some of that learning is international learning from scientific studies, but as Rafiq was alluding to or saying in his presentation, we learnt a lot by looking after COVID patients here at St George's. So we've learnt that it can be very serious, obviously. We've learnt that people with COVID-19 can deteriorate very quickly. We've learned that people who are sick at home need to contact healthcare services quickly. If they're deteriorating, they shouldn't just wait to get better, because sadly we did see some patients presenting very late, and that does carry a risk of death. We've learned that it's a disease which can do the unexpected and can place a very high burden on intensive care services. And of course, internationally, with all the research that has been done, we've learned that there are a few treatments which appear to be somewhat helpful. I would say probably the most important thing that we've learned is that social distancing measures work. So I think in terms of actually keeping people alive and keeping the population well and learning that's relevant to all of us, what we've learned is that we need to take social distancing really seriously. We need to take infection and prevention and control measures in healthcare and care home settings really seriously. When the government introduces new measures to stop us from our previous normal ways of life, we need to take those seriously. And those are the measures which prevented this and all our other hospitals in the country being overwhelmed when we had the last wave of COVID. The only reason that we managed here at St George's or anywhere else in the country to the extent that we did was that people observed the social distancing measures to the extent that they did.
Thank you very much indeed, Richard. Chris.
Thank you, Gillian. When will visitors be allowed back into the hospital?
Thank you very much. That's another one for Rob Bleasdale, who's our chief nurse. Rob.
Thank you, Gillian. So we acknowledge that many of our patients who are in hospital would want their loved ones and relatives and those close to them to visit them while they're in hospital. And through COVID, we had to respond very quickly to reduce the amount of members of public and footfall, as we call it, people coming into the hospital site, so that the risk of bringing infection with them was less, but also the risk of catching anything reduced as well. And that was responding to a national directive for us to stop all visiting within the hospital at the peak of COVID. As Jacqueline said in her presentation, we supported new and novel ways of allowing relatives to keep in contact with their patients through the use of iPads, nursing teams to keep in contact with relatives, messaging services through email. As we've come through the first wave of COVID, we've started to reintroduce our visiting. Initially, we reintroduced visiting for those vulnerable patients, so those with dementia, learning disabilities, those patients at the end of life, as well as introducing visiting for women having first scans and birthing partners through labour, as well as one family member attending if you have a child whilst in hospital, and only that one family member attending. That has been difficult. We know you want to come back and visit your loved ones in hospital, but we're still managing visiting back onto the site slowly and cautiously whilst we implement rigorous infection control measures on the site. We are expanding that visiting now, and we will be updating our visiting policy within the next 2 weeks to broaden that wider, to allow one person from a family member or relative to visit patients on site. So that will be coming out in the next 2 to 3 weeks.
Thank you, Rob. I'm sure that'll be very much welcomed. Right, Chris, next one. I think we're managing to get through the questions actually. So, Chris.
Thank you, Gillian. What are the long-term plans for Queen Mary's Hospital in Roehampton, which the Trust runs?
Thank you. I think that's one for the Chief Executive, if you don't mind, Jacqueline.
Not at all. So Queen Mary's in Roehampton is probably the best bit of building stock we've got. It's a beautiful facility, great car parking there. And we also know that in September 2021, the mental health unit moves out from there, and that means there are 3 wards empty. We also know that there's quite a lot of void space there, so space that is not utilised as well. With COVID, it's given us an opportunity to think about how we might use that facility. We've talked quite a lot about the fact we've had to cancel elective patients during the COVID time, and we've spent quite a lot of time. And I was out with the chairman yesterday, with the chair of the integrated care system, and because I've not really been around the organisation as much over the last 6 or 7 months, everything's moved because we've had to make green areas which are for planned patients that are COVID free. We've had to make amber areas, we've had to make yellow areas and blue areas, all to segregate and keep patients safe, either who have COVID and need treating and co-locating together, or who might have it, who definitely don't. And it's quite difficult to do that in such big organisations. So we want to think about how we might use the Queen Mary site to be able to do more elective work so that we don't have some of the issues we've got to, which are quite complicated in the organisations across South London, and we can keep patients safe in a very what we call green environment. But those plans are only at the discussion stage rather than not. But we want to use Queen Mary's in a productive, helpful way, because it's part of the local community. It's got a long history, and we want to make sure we utilise it as fully as possible.
Thank you very much, Jacqueline. Chris, next one.
Thank you, Gillian. What is the Trust's sense of what staff morale is like at the moment, particularly given the pressures of recent months?
So I could ask a lot of people to comment on this. I wonder, Elizabeth, if you would like to start, and then maybe Humaira add something, given your joint Chief People Officer role, and then the Chief Executive may want to add something as the person with overall responsibility for running the hospital. Is that all right?
Thank you, Gillian. Me and my colleague Humaira, of course, take a temperature on what's going on across the Trust. Humaira is more close to this, given some of the focus groups and that she usually has with our colleagues. So I'm going to ask Humaira to begin by just sharing what has come out of the focus groups. Humaira.
Yeah, so I think it's been alluded to that we are going through a very detailed diagnostic process to understand the culture of the organisation. So we're doing this not through external people, but we're doing this through engaging our own staff to collect data on focus groups from a whole range of staff and questionnaires and board interviews. So we will get much more of a detailed temperature once we've got those reports, which will be developed in the next few weeks. But on an ongoing basis, we have a number of groups, a number of vehicles by which we get information. One of those is we've got a health and wellbeing staff support group that meet every 2 weeks, and it's made up of health and wellbeing staff. It's made up of staff support people, counsellors. Those are the people that if you've got issues or concerns that you go to for counselling. We've also got a number of clinical health psychologists in that group, and what they do is that they obviously pick up things from staff on the ground, and they bring them to the meeting every 2 weeks, and they pick up the main issues. And what we've done to date is that we've had a health and wellbeing bulletin that goes out, used to go out every 2 weeks, it now goes out every 3 to 4 weeks, where it addresses some of those issues. And we also pick up those sort of address those issues through interventions that we might make, etc. So that's one of the ongoing ways which we do that. We have obviously had some specific events for our BME staff, listening events, where during the sort of the midst of the peak, where there were major issues coming up, and we held a number of listening events. Those listening events were very, very challenging to hear, but they were also very useful. And what we've done with the information that we picked up in those listening events is that we incorporated that all into our diversity and inclusion action plan. So all of the deliverables in there are absolutely linked to what people were asking us that they were concerned about and that they wanted changes to happen. So we're doing a number of things to try and listen and support our staff. And of course, if you can well imagine that in this particular environment with the social distancing, that has become particularly challenging, but we are doing this as much as possible face to face, but if not face to face, online. So we're keeping connected throughout. And there are obviously other means, but those are some of the key areas that we're looking at. Is that okay?
Well, it's very okay for me. I hope that the person who asked the question found it useful as well. Thank you very much, ladies. I don't think there's any need to ask the Chief Executive to add to that. And she hasn't indicated she wants to. So, right, Chris, next question.
Thank you, Gillian. I'm very concerned about the impact of COVID-19 on junior doctors, many of whom would have been exposed to new and very different experiences very early on in their career. What has been done to address this?
Thank you very much. I think, Richard, that's one for you. Richard Jennings, who's our medical director. I should have introduced him properly when he answered the last question he asked. Richard.
Thank you. I think COVID-19 had a huge impact and has a huge impact on our junior doctors. Our junior doctors' working lives were turned upside down by the first surge of COVID cases. All their normal rotas and activities were completely changed, and indeed their training, because of course our junior doctors are all training to become specialists. Their training was interrupted as they were reallocated to different areas. But in addition to that, and I think perhaps what this question is about, they're newer to the profession, and they faced really remarkable circumstances that I didn't have to face when I was a junior doctor, and none of the consultants here have had to face, certainly in this country, when they were junior doctors. On the issue of their training, I think their training and education is gradually getting back to a much more stable position, and they've been able to rotate onto the training posts that they were meant to rotate onto. In terms of their working hours, that's become a lot more stable and normal than it was. In terms of the impact on emotional well-being and the stresses and the difficulties of looking after patients with COVID, we've done a great deal to try and support our junior doctors and indeed our senior doctors with the pastoral aspects of what COVID has been like as an emotional experience. And we've put a lot of work into trying to make sure that there is psychological support available for teams and individuals, that there are opportunities to debrief, that there is counselling, there are opportunities to share stories and reflect on them, and that individual people with individual issues receive individual compassionate, kind and thoughtful and flexible support. So nobody underestimates the magnitude of the emotional impact on our staff of what we've just been through, or indeed the resilience that we need to keep going in anticipation that COVID, hopefully not in quite the way that it came last time, but the COVID will come back again.
Thank you, Richard. Chris, I believe we're getting towards the end of our questions now, are we?
That's right, Gillian. We've got, I think, a couple more.
Okay.
Yeah. So actually a question for Dr. Badair. Bearing in mind, on the one hand, it's common use in China and other countries for IC patients, and on the other hand, the risks from high dosage, did you use or consider using chloroquine as part of the treatment?
Rafiq, you're still there? And well done, Chris, for getting that pronunciation absolutely spot on. Rafiq.
Thank you, Gillian. Thank you, Chris. In the UK, and certainly in intensive care practice, we have a very rigorous approach to the evidence base that we will use for using drugs and interventions in particular situations. And there wasn't even at the beginning of COVID, there wasn't enough evidence to support that using it would be beneficial to patients. And then the emerging evidence at a later stage suggested that in some studies it would have no benefit, and in some studies that it may be harmful in particular groups of patients. We didn't use hydroxychloroquine at any stage in our treatments of patients.
Thank you very much indeed, Rafiq. So this must be the last question coming up, Chris, is it?
Apologies, Gillian, I miscounted. We have two more, so this will be the penultimate, and then one.
Quite all right. Quite all right.
So the question is, what preparations is the Trust making for a second wave, and is the Trust ready?
Thank you. So that's a question we ask a lot. I think it's probably best for Avi, our Chief Operating Officer. I hope that your link's working at the moment, Avi, is it?
Yes, it is. Yes, it is, Gillian.
One for you?
Yes, it is. Absolutely. This is something that we've been working on very hard over the last few months, actually, and learning from the first COVID surge. Obviously, there were things that we you know, we've heard a lot about the exceptional thing that our staff did, their professionalism, their skill and their resilience through the first COVID. But there's lessons to be learned as well, and how we could do things differently next time. And of course, next time might be just round the corner, particularly the increases in cases that we are now seeing in the community more generally. So being ready is absolutely key. We've been working very hard over the last couple of months in developing what we've calling a winter plan, but it's a winter plan with obviously to deal with the, you know, what we would see in a normal winter. So it includes increase in patients with flu. It also includes, you know, the usual things like norovirus and how we would manage patients like that. But obviously, in addition, this is obviously a year like no other. It details how we would manage COVID. The key principle that underpins our planning now is that we deliver excellent care to patients with COVID, but also non-COVID patients. So, you know, how do we manage the hospital so that we can keep elective activity going whilst maintaining managing increases in COVID patients that go into our general and acute beds, but also with increases in patients going into ITU. And there's a number of ways that we will need to do that. You know, the workforce, we've talked a lot about workforce, and we've heard a lot about, you know, from Rafiq's presentation, how we deployed staff to help ITU staff, some staff that had never worked in ITU before. We will need to do an element of that, but we have also built in more resilience into our workforce, particularly junior doctors in critical care. We'll be increasing the nurses into critical care and on the general wards. We're looking at how we can provide more sort of high dependency care to respiratory patients outside of intensive care to increase our capacity there. We're looking this time to keep day surgery units going, keeping endoscopy going. So trying to continue to do elective surgery for as long as we can, as safely as we can. But again, that if we need to, stepping it down in a timely way as well. So it's going to be a lot more this time, a balancing act of keeping elective going whilst dealing with our emergency patients, having a more resilient workforce, i.e. an increased number of workforce, and having more equipment to help us keeping more areas going. Also, you know, what's been very apparent in the first surge and will continue to be is partnership working across Southwest London and further afield. So working with other providers in Southwest London and making sure that we are making the best use of our resources for our patients across the whole patch and further afield.
Thank you very much indeed, Abby. So this must be the last question now, Chris.
It is this time, Gillian, thanks. What can the public do to help? COVID-19.
Yes. So I think I might start with Rob and then maybe Avi. And if they hate me for that, my apologies. Rob, would you like to start that one?
Thank you, Julian. So I will be repeating some of the messages that my colleague, Dr. Richard Jennings said earlier. I think, first of all, echoing Jacqueline's point about the thanks to the general public about what they have already done through the first wave of the pandemic, both in maintaining adherence to government guidance, but also showing their public support to colleagues working in the health service and care setting, and that's been greatly appreciated, I know, by many of our staff and contract workers. I think for me, adherence to the government advice around the importance of social distancing and maintaining social distancing, regular hand hygiene, the use of face coverings in closed spaces, when you're shopping, when you're on public transport. If you feel unwell, that you self-isolate and phone 111 and seek guidance around COVID testing. And I think for me, the main bit there is following government advice, social distancing, hand hygiene, regular hand washing, avoiding touching your face. We know this is droplet spread and respiratory spread through your face, so don't touch your face. I know I do it all the time because I have a beard, but try not to. and if you feel unwell, self-isolate and phone 111. And also there is public advice on the government website and Public Health England website about how to get tested if you feel unwell and think you might have COVID. And then if you want to help the NHS more broadly, there are initiatives and volunteering schemes on the NHS website, but also a shameless plug for St George's. We have a wealth of jobs and opportunities here at St George's, should you want to come and join us and work with us.
Oh, well done, Rob. That was a very nice concluding point. Abby, was there anything you wanted to add?
The only thing I would add to that, Julian, is that if the public do need to access our services, then they should access our services, because we've seen a drop in referrals and patients coming in. So we are open, and if you do need us, then use us. But I think Rob summed it up beautifully in terms of general principles.
Thank you, Abby. I think that point you make though is so important, that if people are worried, we are here for them. There was some evidence of people staying away when they needed us, and we want them to come. So that brings us to the end of this evening's proceedings. After that rather shaky start, when the technology seemed to be letting us down and we couldn't all join in as we would have wanted to, I think it settled down and we all became a bit more comfortable with it. I'd like to make a number of thanks. First of all, I'm told that in the chat room, which I'm not able to see, there's been an awful lot of supportive comments of the Trust and its staff. And thank you most sincerely for that. The support of our communities and our patients is so important, and I think COVID illustrated that so graphically. I want to say thank you to a group of people who don't always get a lot of thanks, and that is the executive directors of the Trust. Everybody was very conscious about what was happening at the front line, but for my executive director colleagues, they were working just as hard, often in very difficult circumstances with inadequate information and in a real emergency situation. And I think they rose to the challenge magnificently, and I'm enormously grateful to them all. As Jacqueline says, she'd only just herself come back from quite a severe illness, and she had to do it while shielding, but the team worked together brilliantly. I also want to say thank you to my non-executive colleagues. We've had to learn a lot of new skills, like how to run and participate in meetings via the internet, and we have got better at it, despite the conclusions one might have drawn from the beginning of this meeting. I've also made my thanks to governors who are there as our supporters and challengers. But most of all, I wanted to thank all of you. I don't know how many of you there are. I'll hear all that later, but I wanted to thank you all very much for attending our meeting, for listening in. I hope it's been informative and useful. And I do hope that you've been able to access most of it, as I say, despite the initial hiccups. And a final thank you to the governance team and the IT people who did work incredibly hard to make this work. It's very hard to do a meeting that's got people in one room, other people all over the place, and members of the public joining in. And I am very grateful for all their efforts, even though I was a bit irritable at the beginning, because I think we got there in the end. So a very warm thanks to all concerned, and a good night from me. Thank you very much indeed.